Okay, the wee thing in the corner is claiming that we're live. Don't know if I believe it or not. I'll soon see. I've got the other computer running and things are happening on that, so it seems to be live, actually, really, truly. Anyway, I wanted to do this hangout because I know that out in the world in general, there are a lot of myths about cancer. What cancer is, how it occurs in people, and what it does to you, why it is so lethal, why there are such difficulties in attempting to treat cancer. So I thought, do we hang out with some people and talk about the very basics of cancer? So I had made myself some notes and I'd rounded up some people. And trying to round these people up is like trying to herd cats. In other words, you're on a hiding to nothing. But I've got 2 cats here now. So anyway, I'm starting off with the real basics of cancer. Cancer is one of those diseases. I say one of those diseases. What it is it's a group of disorders depending on where the cancer is and what type of cancer. And a cancer will arise when a normal cell, for whatever reason, loses control of its replication process and it starts to replicate out of control. So all these normal control mechanisms are lost. Well, why is that a problem? Well, it's because if you've got one little cell sitting somewhere that suddenly becomes 2 and 4 and 8 and 16 and 32 and 64, and it keeps doubling, it starts to take up space and it'll impinge on other parts of your body. So here we have our hogtie champ, and he's going to explain some of these real basic pieces of information about cancer and what is going on there. Over to you, hogtie champ.
Oh, thank you. And are you going to let me get away with this? I think the way that I would want to approach this kind of for a YouTube audience, which always have the mix of sort of both sort of background levels and interest levels, is I can kind of talk about it a bit in terms of a good way to understand, a good way to think about what happens when people get cancer in their bodies. And then rather than going too far into technical details, I can give you some reference to sort of, for more information, click here. So for example, I'll need to talk a little bit about proliferation as part of the healing stages. And without necessarily want to venture into a big discussion about what the actual mechanisms are, the chemical messages that are involved in proliferation. But given that I've now said the word and almost pronounced it correctly nearly twice, proliferation, people will know that this is something that when we're talking about that's the kind of thing to go look up. And that information is really accessible. I mean, there are even YouTube videos and that sort of thing. So I guess most people are aware of sort of a changing attitude about cancer. It used to be you heard this word and it was just this awful thing. Like somehow cancer is an attack on the body. We continue to use the word that way figuratively when people will say, oh, the Democratic Party is a cancer on the United States of America. We really mean that it's like this invasive, dangerous, destructive sort of a thing. And I'm going to suggest to you that when we're talking about literal cancer, the first uncomfortable notion to bring to mind is that you need to not think of it as a foreign, destructive force, but rather it's a natural running of the course of a very natural thing to happen inside a human body. So while it is certainly the case, I don't mean to imply that there's nothing outside that quote unquote causes cancer. Certainly there are environmental factors that will increase the likelihood that you're going to get cancer. And there are many environmental factors that are going to indicate that you can get rid of a cancer once you've gotten it. The point is, don't think of the actual tumorigenesis, the actual creation of a cancer tumor, as something that's just this completely alien invasion from somewhere else. It's actually an extension of your natural body processes. So if it's okay, where I'd want to start is to talk a little bit about what an actual what a tissue is. Like when we talk about, and I'm specifically I mean basal membrane tissue, so tissues that form membranes. So this is going to be different from something like blood, where blood is considered a tissue, but it's not a membrane. So if you had a whole pile of red blood cells, you've got a whole pile of red blood cells. But when you look at other tissues that would tend to form membranes, whether they're skin cells or epithelial cells, anything that forms the various layers inside your colon, for example, colon's a very popular place to get cancer. It's quite trendy, get cancer of the colon. Those things obviously have a very different character. If you have a pile of epithelial cells, there's a structure to it. They're not simply piled up. So the thing to think about, so and with that clarification, I got to say too, I'm not going to say anything about leukemias, for example. I mean, leukemia is a subset, but there's many different leukemias. It's a different set of conditions there. So that would, I'm just to try to narrow it down. I want to talk specifically about tumors. Now, these are phenomenon of basal membrane tissues. So from the experience of poking your own skin that there's a certain vitality to it. Your skin isn't just just a covering, right? Like it's alive. There's a vitality to, you can pull it and stretch it and that sort of thing. And it's not simply achieved by having membranes bump into each other and kind of glue each other, glue the membranes together. If you think about it with some understanding of how membranes work, you would realize, well, that really wouldn't work if there was any sort of connections, that the whole system would just fall apart and it would interfere with the membrane bound proteins. I mean, that simply wouldn't work. So you need to kind of think about human tissues as, and again, I mean membranes, as like neighborhoods. And I'm going to do this weird thing here where I'm going to kind of anthropomorphize the cells a little bit, but then remind you that these things are not really conscious, right? So there's a way that when cells of the same type come together, that they're able to announce to each other through signaling that we're friendly cells. You're kind of a lot like me. You're my neighbor, and I like you, and I want to stay being your neighbor. So they will build bridges. There's different forms of microfibers that will cross one another. Collagen is one of the more common ways that you can actually bind one membranous tissue cell to another membranous tissue cell. And of course, this is all in a big sheet, right? And then there's another mechanism to interconnect sheets to other sheets, thick layers of tissue, and eventually build a cortex over an organ. So for example, the kidney has this cortex that goes over it, and the cortex is actually made of interconnected sheets, each sheet being made of these interconnected cells, right? These membrane cells. So the thing about these neighborhoods, there's the cells will interconnect with each other. There's messages they will send to each other, and they, let's put it this way, kind of live a happy life. And I'm going to try to I'm going to whip myself forward a little bit rather than babbling too much. I'm going to try to. I think the thing to think about here too is what happens when not everything goes well in the neighborhood. So you get a tear somehow, right? So you get a bullet hole in you, right? You get surgery, you get a cut, you get a burn. You, in addition to having this mechanism that sort of holds the neighborhood together, you have to have an emergency response system that's able to bring the tissues back together. And then now you got a problem because you have all these friendly cells, right? So this type of a membrane cell is going to be close to some other type of membrane cells, but in the space in between where there's no longer any connective strands, there's going to be a whole bunch of other cells. Many of those will be bacteria, and they're not fun-friendly bacteria. These are often necrotizing or just something else that interferes with the healing process. So now that tissue has the dilemma of like, well, I need to start forging friendships and finding my old neighborhood buddies. But I also need to avoid interacting with cells that are pathogens. And here's the real kicker of it, is that they have to be able to make all these decisions, but they're not actually making decisions. They don't have any brains, right? So it's all got to be done through chemical messages. So here's a part where I'll make reference, again, to sort of keep up the pace and not try to turn this into an hour lecture for me, but to sort of tell people that if you want to kind of learn about how that process of healing works, is this is where you want to look up something like, the steps of tissue healing or something, and there'll be an inflammation phase, and then there's the where your body will build up these capillary cells around. So you got a bunch of cells that are interconnected to each other, and then you've got a break. There's a point where you've got a cell on the end, and there's just no next cell. You just got a big empty space, and it's full of bacteria. So what it'll do then is it'll build up a layer of capillary cells, and the other side will be doing that same thing. And then through these other mechanisms, the inflammation mechanisms, there's a contraction mechanisms that will actually serve to reduce the size of the void, and will bring these tissues together. And eventually you'll get a bed of capillary tissue in between that set of cells and the other set of cells, and the bridge will start being built around this capillary tissue. And proliferation tissue is not like, well, it's a scar tissue. There. Why am I going to talk long about this? This is real simple. Have you ever noticed that when you get like a cut on your skin, that it'll be all funky and monkey for a while, but then you'll get kind of this thin layer over top that kind of looks like skin, and underneath there's some meat under there, but it's not the right color. And then over time, that color will sort of reduce, and it'll start to look like normal, but it sometimes takes months. That's because that cell is made of, that tissue underneath is actually made of a different type of cells. And again, I would encourage people to look up cellular repair, cellular proliferation, to understand how those cells are different. I mean, the short answer is you're actually building up capillary tissues, which is different from other skin tissue. And the same things happens in the cortex, the kidney. The same thing happens in the lining of the small intestine. And so that's sort of the low-level flyby about how tissues heal themselves. The reason why I mention this thing about they're not really thinking, because they don't really go to each other's house and say, "Oh, you're my new neighbor. Here's a plate full of cupcakes." They have to rely on these chemical messages, and they don't know that there's an injury, that they're near an injury site, and that they need to do something to heal. So they kind of rely on these friendly and enemy, identify friend or foe chemical messages. So here's my question now: what happens when you get one cell that has some sort of a genetic conversion? For some reason, this cell gets into a growth phase, grow, divide, grow, divide, grow, divide, and it starts to make a bit of a lump in the membrane. And the lump gets to be so big that it actually starts to bend over and touch other cells of a similar type. Right? So I want you to think about the inside of a colon, for example, where you have these membrane tissues. And remember, the colon's a terribly abusive place. There's stuff, food bits and stuff scraping through it all the time. It's always getting little cuts and nicks. So it quite often gets tears, or stuff pulls away, and then it rejoins and regrows. That's all very healthy stuff. But what happens if one of those cells goes all wonky and it starts to get into these rapid growth divide, until it actually makes a little nodule that's so big it actually bends over and starts to touch other adjacent cells? Doesn't it seem obvious that those cells are now going to recognize those cancerous cells as friendly cells, and might start to go ahead and build, capillary, build a little proliferation bed, and actually seek to make that connection permanent, and seek to provide blood vessels and nutrients and everything else to keep those cells alive? I kind of want to wrap up on that point to sort of encourage other people to add to it and discuss it. But I'm wondering if this idea of thinking of it as a neighborhood, but then one of the neighbors goes crazy and ends up having 1 million, kids, right? And actually warps the whole neighborhood to where it bends over, and they start building more connections to the sort of crazy part of the neighborhood, that there really wouldn't be an automatic mechanism to figure out how to not bond. It would actually go right ahead and proliferate new tissue and really welcome the tumor into the fabric of that overall neighborhood.
Can y'all hear me? Actually, can y'all hear me?
Just about.
Okay, I'm not on my good laptop, so I'm putting my face right next to the little microphone thing. But did we discuss kind of how the body identifies like pathogens as opposed to regular tissue?
Well, I think I was the first one to talk, and I kind of only had made, only the point that this is how we recognize, how they recognize friendly. In fact, I didn't even say how the tissues recognize friendly tissue. I was just sort of laying out the groundwork for the idea that it's important for basal membrane tissues to recognize their own brethren and to want to forge relationships, to forge these collagen strands, and in the case of an emergency, forge these capillaries as proliferation, with the adjacent ones. And I don't think I'd really said anything. I mean, I mentioned that there'd be some pathogens, but I didn't really say anything about how they recognize the pathogens or really what could or should be done about it. I've said nothing about that.
Okay. Okay. I'm just going based on memory, so someone feel free to correct me. I believe it's the histocompatibility complex 2 protein that's on the outside of certain cells that allows the immune system to identify this is friend. And so even when, you know, in your analogy, the crazy neighbor that has a bunch of kids, the body's not going to really recognize that as, well, there's a crazy guy having a bunch of kids and it's going to wreck shit because he has that histocompatibility complex 2. But as opposed to when there's a pathogen and it's proliferating, well, it doesn't have that. So it's the immune system is going to respond to that. So for those of you who are wondering why your body just doesn't kick in, and I want to really emphasize this, your body doesn't kick in to eliminate cancer because it still is your body.
Yeah, and just to follow onto that, primarily the immune system, well, almost entirely the immune system is targeting things that are there but shouldn't be. That's why you talk about, you know, antigens, right? These are things that the immune system recognizes as bad and attacks, but there isn't anything. I mean, you can talk about what is there, you know, MHC2, but more importantly, there's nothing there that shouldn't be, especially in terms of, you know, hopefully when cells go wrong, they send out signals to the rest of the body that they, you know, they need to be taken down. And when that process gets cut down, then you have real problems, because now suddenly the cell's not signaling that it's in bad shape either. So
Yeah, because one of the I'm looking for the word and I'm struggling for it. One of the approaches that they have tried with cancer is immunotherapy, but it's only going to happen, it's only going to work if the cells within the tumour have something on their surface that can be recognised. And not all tumours produce something on their surface that can be recognised as being different from all the other cells in your body, because the cancer is part of you. It's your own cells. So it's obviously not going to be recognised as foreign just because it's multiplying out of control. But there was some work done with, I think it was a type of melanoma, where they used immunotherapy and they seemed to get very good results, but it was a long, long time ago. And I'm not quite sure what came of that. I would need to have a look at it. But
I think I recall. Can you hear me?
Yep.
Fiona, can you hear me? Okay.
Yes.
I recall the immunotherapy you're talking about. Melanoma now is with several monoclonal antibody therapies. They're getting remission rates in the high 90% with these new therapies. And one, Wonk mentioned PD-L1. That's a very good example for people who are familiar with the monoclonal antibodies and the tests that are run to diagnose melanoma, and which treatment will be most effective for patients.
Yeah, so basically what we're saying is the cancer is, it's part of you that's gone wrong. It's not extrinsic. It hasn't appeared from outside of you. It's part of you. And that's why it can be so difficult to find a treatment for the cancer, because you've got to treat that cancer. You've got to kill those cells while not killing you in the process. Now,
while not killing you quite as much.
Well, yes. But one of the things I wanted to get into was, what is it about a cancer that makes it so dangerous to you? And I'm talking about the type of things like space-occupying lesions, especially inside the skull, or blocking the gut. And then there are also those tumours which pump out high levels of things they shouldn't pump out, because the control mechanism for that has been lost as well. What I was wondering was, could hog tie, if you're still there,
Yeah.
explain some of these these gross mechanical effects?
Yeah, and I might be able to do that with some brevity. The interesting thing about, and again, I'm very much focusing my comments on these basal membrane tumors, and there's a kind of a morbid way that they actually cause harm. But here's the interesting thing about it, is that most of them actually don't cause any harm at all. This is part of the reason why I wanted to introduce the idea of how these cells kind of help each other, stay alive, and then how they specifically with getting blood vessels. Because if you think about it, if all you had in your lining was in your stomach, in your intestinal lining, for example, was one cell that turned into a tumor, and sorry, it's not turned tumor, it just kept dividing and dividing and dividing and dividing. Well, eventually it's going to get so big, it's not going to be able to keep itself up, because where are these membrane tissues, membrane cells, where are they getting themselves, where are they getting their nutrients from? It's just a big wad of cells, right? So the very fact that these things ever survive is itself remarkable. And so that's the important bit of information to make sure you kind of have in your mental tool bag when you think about cancer, is that the reason they're able to stay alive is because the body supports them in the same way that they support all of the other cells of your basal membranes. So they get blood vessels, nutrients delivered to them. They get regular inspection and cleaning by the immune system, just like anything else, and your body keeps them alive. Now, since they're not a part of natural morphology, sometimes they grow into shapes or sizes that don't permit proper blood vessels. So they actually then just starve out and they die and they break off and they go away. So the current thinking on this, and this is going to sound weird to the audience, you've got to keep in mind, this is sort of thinking from the last 10 to 15 years of cancer. So this is not something that you're going to see in sort of the popular, news that's based on books that were written in the 80s. But the majority of these basal membrane cancers suffer what they call a spontaneous defeat of cancer. So you'll get some cells that'll go into what they call carcinoma in situ, or stage, if you go by the AJCC staging system. This is stage, so you look up AJCC, American Joint Council on Cancer, I think it stands for, stage 0, or carcinoma in situ. It just means a little nodule of cells that have gone through this rapid division. In the event that they don't get proper blood supply, they just die off as a group. That whole part of the cells just tears off and it goes down the colon, for example. If it's colon cancer, it just goes in and it passes out and it's not really a problem. So that's the good news. The bad news is that sometimes they actually do get a healthy blood supply, and they do continue to be nourished and maintained healthy and clean by an active immune system, and they are nurtured and they grow. Now, in the case of the colorectal cancer is kind of my favorite example for this stuff. They can actually grow to be big enough to where they actually impair the mechanical functioning of the colon. And this is the point I think Fiona's getting at, that is kind of alarming and bizarre and just mighty interesting, is that having these cancer cells around itself isn't that bad, but they actually get to be big enough as a mass to where they start to cause blockages. I'll share this one little funny thing. It's not funny. It's not funny. Why am I making jokes? One of the symptoms of colorectal cancer is a thing they call pencil stool. Do I need to describe what pencil stool is? Everyone just think about it for 4 seconds. You'll know exactly what I'm talking about. That you can actually get tumors that are big enough this is only if you get it in the descending colon. But it's a real thing. Like people,
is that what you guys call it in Canada?
What's that?
Pencil stool?
Pencil stool.
Is that what you call it in Canada?
Yeah, why? What should I call them? What? It's a real thing.
I'm just curious.
Yeah, no, it's a real thing. And people will come in and they'll comment that, like, oh, nothing else feels weird, but this is a weird thing that's happening in the bathroom. And if you try to look for some bizarre medical explanation for it, there is none. It is strictly an anatomical. The inside of the colon will change in morphology so significantly that people can't pack proper stools, and they'll get these long skinny. So there's that, and of course the same thing. Fiona mentioned cranial limits, right? You can actually get you can get a basal membrane tumor inside the cranial cavity, the brain case, that the tumor will grow to a size that it starts to pinch off important for exchanging nutrients with the cerebral spinal fluid. and people will start having things that appear to be strokes. Are not really strokes, but it's actually they're the side effects of there being a lack of nutrition in different parts of the brain because you're not nourishing the cerebral spinal fluid. So I'll say there's kind of two bad things three things that happen with cancer. One of them is it just generally dies. In the event that it doesn't die, it can grow into a tumor that is mechanically, anatomically disruptive. It changes the morphology of that region, and it impairs with the function there. And then the third thing that can happen, that's where the first one isn't bad, they just die off. The second area splits into two. There's either the physical growth of the tumor that causes mechanical problems, or alternatively, sometimes the cells will break off and they will circulate through one of the two circulatory systems. It can rarely go through the blood supply. More commonly, they'll go through the lymphatic system, and these cells will get trapped in adjacent lymph nodes. And then they die in that lymph node. But if they don't die in that lymph node, they will actually seed in that place, and they will start growing in a nearby lymph node. And now everything I just said about these things being bad for you, just copy paste everything I just said, because that can also happen in your lymph nodes. Tissues from the pancreas, cells from the pancreas, for example, can form nodule tissues and stuff in adjacent lymph nodes. So that's, of course, as everybody knows, that's metastases. So to answer Fiona's question, yeah, it's literally a mechanical intervention of what's supposed to happen in that area, and then second, metastases to adjacent organs.
The other thing that I think you need to think about with cancer is when it starts to replace other tissue because of its bulk and because it is so greedy on nutrients. So, for example, if you think about the lung, if you start replacing parts of the lung with a tumour, you've got less and less functioning lung to maintain your breathing. One of the other ones that I came across, which is one of the ones that sent a chill down my spine, was metastases from malignant melanoma in heart muscle. Because those cells do not, although they are now within the heart muscle itself, they don't function like heart muscle. They don't do what heart muscle should do. But they are busy by their bulk replacing heart muscle. And also I believe that can also kill the adjacent cells because they are slurping up all of the nutrients.
Well, that and sorry to interrupt, Fiona, but that and the other thing I was saying about the cutting off blood supply, for the heart one, that's a pretty critical one, because the heart, although you think the heart is just awash in blood, the heart doesn't really draw nutrients from the blood supply as it passes through. The heart muscle is actually nourished by its own set of arteries. So you want to look up the coronal arteries. There's a kind of a corona, a little halo around the heart that keeps the blood muscle, because it doesn't pick up nutrients from the blood supply inside the blood vessels. It gives to itself nutrients through its own blood supply. And those coronal arteries are a little, the coronal vasculature is actually a little sensitive to things like pressure. So if you get cancerous growth on either the pericardium or the actual myocardial, the heart muscle tissue, it can be big enough. It doesn't have to be that big before it'll start to pinch off the coronal arteries. So everybody here knows what a congestive heart failure is. You get a clot that like blocks this artery, but you can block an artery from the outside too. In the heart, this is one of the, this happens in the heart. You can, if you put pressure on the outside of the artery by this runaway growth, it'll cause what looks like congestive heart failure, but it's not a clot. Yeah,
I like your description of it as runaway growth, because I mean that is what cancer is, that runaway growth of cells. The other thing that I thought would be interesting to just have a wee look at are tumours which produce either something they shouldn't or too much of what they should, and how that then affects the entire body. I know that some of the adrenal tumours will do that. Some of the pituitary tumours will do that, where they overproduce hormones. And so Sorry, on you go.
I was going to say, is it exclusively for like the endocrine system, or are there other systems in which they overproduce that overproduce whatever the product is that would cause some type of catastrophic effect on the body? Because the only ones I've heard of are endocrine.
Yeah, I don't think it is. I don't think it is. I can't see. This is the thing. I've got my notes written on Chrome, and I've had to shut down my Google Chrome internety thing because the blinking memory on this blasted Chromebook is struggling.
Well, if I may, there are several lung cancers that actually will start to produce excess hormones. I'm thinking of like small cell lung cancer. It's very notorious for creating what are called hormone-related peptides that mimic natural hormones in your body, and they will mess with your metabolic system, will cause you to have deficiencies or excess of certain elements like maybe potassium or sodium. And those, like, depending on what type of tumor you have, correlates with the possible types of hormones that could be made in excess. And that would definitely cause disease beyond just your cancer and tumor.
So you're getting system-wide effects then?
Yes, you're right. System-wide effects from a localized disease process.
Yeah, we're not painting a happy picture here, are we? No.
I was wondering if, Fiona, maybe you could go over the difference between tumor and cancer, or maybe you guys had already talked about that.
I don't know if I wanted to get into it quite as much as that, but having said that, on you go.
Well, I was just going to say that I think Hogtie really gave a nice definition in the intro. A tumor is basically any abnormal growth of tissue in the body, but cancer is a more specific subtype of tumor. It's a type of tumor that's aggressive, that invades, that will detach and go to other locations in the body, and with time, unfortunately, cause problems wherever it goes.
Yeah, because that's where we differentiate between a benign tumor and a malignant tumor. The malignant ones are the ones which are not going to stop. They're not going to stay localized in one place or stay at a reasonable size. They are just out of control. They're the hooligan of the pack, so to speak.
Yeah,
true.
Yeah, that's a good point. Actually, I think, I mean, I know you said you want too much technical detail, but I think RSC is absolutely right about that. I think we should pause to fix that a little bit.
Yeah.
Because I do think maybe we should have a good working definition of what we mean by cancer. And I want to clarify, when I was talking about tumors, I sort of immediately swept away the thing, well, I don't necessarily want to get into like the leukemias, for example. I said, I really want to talk about basal membrane tumors. And then everything I said after that, my recollection was really to stay focused on malignant tumors. Mm-hmm. Now, some of the things I said would also apply to other forms of tumors. But that was not really my intent. I was sort of saying like you can take, if you were to Venn diagram this, there's such a thing as cancers that are not tumors, and there are such a things as tumors that are not cancers. And I was trying to get at the intersection there. I was really trying to talk about those tumors that are cancers. And while some of the things I said might be true of other tumors, even true of cysts or abscesses, I really was trying to stay focused on kind of the cancer side of it. Well, how do we fix this? So, RC, do you have a handy? What do you think is a good? What do we want to say cancer is?
No, I think what you were saying is appropriate. We want to confine our discussion to cancer. So when we're speaking of cancer, we're talking about abnormal tissue growth that is invasive, that is destructive, that causes symptoms that ultimately will lead to mortality, morbidity, if not treated in an effective and timely manner.
Yeah, well then, see, now I'm going to have a problem with that, because I don't subscribe to the certainty of mortality. the certain immortality view of cancer, because in my view, you have a thing. So in this case, we say so cancer refers to a particular genetic transition, right? That's your oncogenesis, right? So there's a transition, and tumor genesis is the formation of the actual physical thing that grows, and then the next step would be then that thing dies. So generally speaking, these tumors are not fatal in people. They usually go by. They come and go unnoticed. So I wouldn't want to include as a necessary element of either cancer or tumor, or especially malignant tumor, carcinoma. I would not want to include the necessity that a lack of intervention would cause death, because in my understanding, these things come and go unnoticed quite often. Mm-hmm. So there's a typology of tumors. There's a typology of things that go wrong with cells, and I'm saying that even in that type, where they have the potential to cause morbidity and mortality, in actuality, your body's able to pass them without necessity of the person dying. So,
okay, I apologize. I was thinking on a bigger scale, that you wanted to basically steer the conversation only to the types of tumors that
people find
we would
out
talk about chemotherapy and things like that.
I mean,
you want to talk about them all in general.
I'm cool with that.
Yeah, it kind of sounded like you were talking about the types of cancer that people find out about, right? Because if you have carcinoma in situ that just dies before it even hits 2 millimeter, you're never gonna know that you even had it. Mm-hmm. In all probability, unless there's something really weird that happened to be going on at the time that I don't even know why you would learn about that. So if
you got an MRI or something,
right? Yeah, and they happen to notice that, and they happen to biopsy it, and right, yeah. So if we're going to strictly talk about the things that you expect people to actually find out that they have, that's a very different conversation than all cancers. So.
Yeah, and I think Hogtie made a very good note earlier that kind of saying that, in the way that we're looking at cancer here in this discussion, we're talking about everything that happens in the human body, and including the 90 to 95%, which the body, through its natural immunologic processes, gets rid of, destroys on its own. It's only that small percent that get beyond the immune system's grasp. It's what we think of in the medical situations where you're in the. So I'm glad that Hogtie cleared up that we want to look at in this discussion, not just the ones that go on and require treatment. Is that right, Hogtie?
Hoggles.
So I guess we can start the conversation by talking about why even these types of cancers that might just be transient still have harmful effects on people, on the body. What do you think?
Well, I want to stick with the sort of cancer as everybody out there thinks about it. And I think somebody had mentioned in the live chat, and I wanted to sort of mention it. What somebody had brought up was metastases, and how that works. And what I was going to just say was that for metastases to happen, a very small part, can just be a couple of cells, breaks off from the original tumour and can enter the lymphatics, as Hogtie Champ had pointed out, and ends up in local lymph nodes. But the lymph ultimately drains into is it the inferior vena cava? But then back into the
inferior or
bloodstream.
superior, depending on location, anatomically speaking.
Yeah. And when we look at secondary tumours, metastases, they always seem to pop up in a distinct number of places. They'll pop up in lung, bone, liver, brain, Why? It seems, why that pattern? Because obviously a cancer can arise anywhere. Why do secondaries seem so limited in their locations? And it seems the reason is it's where you have very, very small blood vessels or very, very sluggish blood flow. And that's where those little cells that have broken off actually manage to sort of settle out of the blood and act like little seeds. Bone, for example, the blood flow through bone is pretty slow. The blood flow through the brain goes through some very tiny capillaries. Your entire body's blood supply, the way it goes through the liver, means that these tiny, tiny, tiny pieces can settle out. Because remember, with a very narrow and very small blood vessel, you've not got a lot of force going through there. And so that's why they settle out in these distinct places. And the thing that always fascinated me was that quite often it's the secondary that's discovered first. And by looking at the morphology of that tumour, they can then work out which tissue the primary tumour arose in. I know of 3 people that had their secondary tumour detected before the primary, and the primary was located based on the histology of the secondary tumour.
You're
I
right.
wondered if anybody wanted to add something about that.
These cancers that you're speaking of that travel to other parts of the body, they retain the basic structure of their site of origin. So like if you said, if you have a cancer that goes to the bone, when a doctor goes and biopsies or takes a small sample with a needle and they look in the microscope, they're going to see tissue that does not resemble bone tissue from other location. And that's the likely location where this cancer traveled from. And that's a small piece to the puzzle, because just because you know that, okay, this cancer looks like it came from the breast doesn't mean you know where in the breast it came from. But it does tell you where you go next with your investigation, what imaging you do next, where to put your studies and focus your attention. It sounds kind of unintuitive that you see something out of place, but actually it's helpful in making the diagnoses just a little bit faster than they would have been treated 20, 30 years ago.
Yeah.
Before those kind of obvious. Now that people have been practicing treating cancer for so long, it's very obvious to us now, because it's all hindsight almost at this point.
Yeah, that's I think that's one of the things that needs to be highlighted, that we are still learning so much about cancer. I mean, the very basics we know, but there are so many other things that we still have to find out about it. And also, I think I'll maybe save for another hangout about why cancer is so awkward to treat, except to say in this hangout that the problem is it isn't a single disease with a single cause, the way you could say tetanus is. It's each tumour is unique. It has unique characteristics. It has unique gene expression profiles. So therefore it has unique targets where you could target a treatment. And in many cases, you have to find out all of that before you can work out what treatment might be best for any given patient, because there isn't a one size fits all. But I think my fascination with it comes back to system-wide effects from a localized tumour. And also how within a certain part of the body, you can tolerate a huge tumour, and in other parts of the body, you can only tolerate a very small tumour, because it depends where it first arises. Again, that's going to be individual. And so trying to find this one-size-fits-all treatment, I think, I mean, you are on a hiding to nothing with that one. But to briefly talk about the treatments that we have for cancer, whether it's chemotherapy or radiotherapy, the goal is to target rapidly dividing cells. So you want to hit something that they require for cell division. That's going to be your target, because they're dividing so quickly. That's an excellent target. If you can stop that division, those cells are going to just pop their clogs. If you interfere.
I think it's also important. I think it's also important to remember that cancer cells, by and large, tend to be somewhat fragile. I mean, they reproduce very, very quickly, and they're resistant to normal signaling pathways that would kill them. But at the same time, metabolically, they're not exactly in great shape, and so they're quite sensitive to a number of mechanisms, both in terms of actually targeting reproducing cells, as you say, and certain other things that can hit them and basically kill the cancer cells faster and with greater specificity than you damage everything else. But the real challenge when it comes to coming up with treatments for cancer has always been minimizing the harm to other tissues.
Yeah. It's a case of you're going to give something that is toxic, and you're hoping that you kill off the tumor cells before you kill off the patient.
I got to jump in because you kind of, it's funny listening to people who are passionate about chemistry and biochemistry. I don't know if it's funny to an outsider. You just jumped over a whole bunch of stuff. The idea of killing cancer, the idea of killing cancer with chemicals is a really new thing, and I get that. That's sort of your fascination, CRISPR, and I imagine Sam's into that stuff as well. But that's historically that's not how it was done. And I wonder if I can take a moment here to, because I know people like their drama, so let's pimp a little bit. Does anybody remember? There was a hangout about a week ago where I was in for only a few minutes, and I lost my temper with a guy. Was that Dragnet? Was that your channel? Yeah. But I'm exaggerating. I'm just trying to pimp Dragnet's channel. It's worth watching that video though, because there was a guy who came in that was he seems like a caring person, but he's not really interested in sort of having accurate information. And he was claiming that there's this big conspiracy in the medical community that doctors are basically paying for they're funding their in-ground swimming pools by selling poisons to people. And I was a little upset about that. The point that I was trying to make there, which maybe I'll strive to make semi-calmly here, is that understand what happens when a person comes in and they say, oh, I'm having this problem. And then they say, doctors, oh, you got cancer. They're going to say, well, okay, you're a doctor, fix this. I want to not have cancer. So the question then translates to, here's what I want you to do, doctor. I want you to kill these I want you to go into my body and kill these of my pancreas cells, but I don't want you to kill those other pancreas cells. Or if it's bones or it's colorectal cancer, I want you to kill these colon cells, but I don't want you to kill them all. Mm-hmm. So what does the task then become? Because if you went in with a bad infection and he says, oh, you've got, whatever, Latin name for this bacterium here. And luckily the doctor's then going to look for a chemical that we know is ruthless at killing those cells, and yet has no effect on mammalian cells. And they're going to give you amoxicillin or any of these other poisons that are not poisons to us, but they're deadly, deadly poison to bacteria. So how do you selectively kill these runaway growths in the colon, for example? And it's a subtle task, right? And so traditionally, you open a person up, you identify a section a couple inches to one side, a couple inches to the other side. You just take that whole big chunk out. More recently, they'll do things like they'll use radiation. They're getting quite good with conformal radiotherapy, where there's like little, just like the iris in your camera that sort of opens and lets more or less light in. There are little fingers that can not just let more or less light, radiation out at a particular place in the body, but they actually can do it in a particular, they can conform to the shape of the tumor. So you get 3D imaging of the tumor, and then you like blast in this radiation, and you whip this thing in orbit around the body so that you're hitting the same place and you're putting all this stuff through. But there's no way to not also get the cells around it. You just use this conformal approach to make sure that you're getting the biggest bang for your buck. But all of these things, I guess my point here is the very request, please cure my cancer, is to literally tell a physician or a surgeon, I want you to kill, I have some cells in my body that are my cells, and I don't want them anymore. So I want you to go kill those. But I don't want you to kill any other cell that is exactly like those cells. Well, not exactly, because they've converted to this fast replication thing, but they're so close that even the cells of your own body can't tell them apart. But you want a person on the outside to make those discriminations. And they're given the choices of doing it surgically, chemically, or with radiotherapy.
And that actually reminds me of something, which is that you have to remember as well that not all of the cells, even within a single tumor, are going to be the same.
Yeah.
And so you'll have the ones, you'll have some cells that look really bad, right? So some parts of the tissue that look really messed up. And you know, if you're a surgeon, right, and you're trying to cut out this tumor, you see this part of it, and it's like, okay, well, obviously this has to go. But you can't stop there, because you know that the border of that, right, is also probably pretty bad. And then the question becomes, all right, well, how far away do I keep cutting? All right, and you have to, obviously there are techniques to determine that with some reasonable accuracy, but it's hard to draw the line perfectly as here are the truly healthy cells versus here are the ones that are that really need to go too, even though they don't necessarily look as bad as the stuff over here.
You're right, CRISPR. You're right, CRISPR. The doing surgery is very difficult. Technologies that are coming out are finding ways to stain these cancer cells so that a physician or a surgeon is able to visualize which cells need to be removed, stay. But when it comes to figuring out where the border is and how much tissue to remove, I mean, we've really relied on the work of a lot of evidence to determine what is most appropriate for the patient. They've done the standard for a lot of cancers is now to do what's called a wide excision, which is you go several centimeters beyond where you think the cancer invades to be the most beneficial in terms of the risk to benefit ratio. You have a good clearance of the cancer without causing excessive damage that leads to prolonged hospital courses and prolonged recovery time. So I think the way that we've come to the consensus of how it's done currently is the best based on what information we have. And hopefully, as we study more and more what are the best therapies in combination with surgery, we'll get even better at treating these kind of conditions.
I mean,
and maybe I can...
personally, I would say...
So just a quick... Go ahead.
I was just going to say, personally, if it was me, I'd be saying, let's just take off from here and nuke it from orbit. It's the only way to be sure. Because it's a fighting thing.
That sounds reasonable, but
yeah.
Fiona, I mean, I think you know that even if you get the best chemotherapy, even if you get the best surgeon, they can only, on their best day, remove 9% of the cancer cells. So if you think of a tumor cell that's, maybe 1 centimeter in size, how many billions of cells, trillions of cells are in there? So even if you get rid of 99.9%, you're still left with what, 1 million cells? 1 million cancer cells are still in your body, even with that, high efficiency of cancer removal or chemotherapy or what have you. rounds of chemotherapy, but even with the multiple rounds, you're still never able to get to zero.
Yeah.
Theoretically.
Well, that's the dire situation. Remember too that it's quite often people go in for, for example, an appendectomy, and they'll find at the foot of the appendix that there's a carcinoma in situ, and almost never do those people ever get colorectal cancer, because the actual amputation site, so as far up the appendix or even into the cecum, so they generally don't, those people don't get it. I mean, your point's a good one. What they end up doing, and actually, I wanted to connect this to Fiona's earlier point about the individual nature of it and how often where the cancer is in the anatomy is a really big consideration. So if you think about what a surgeon has to do in operating abdominally, so okay, here's a person, we've got confirmed colorectal cancer, how much are you going to take out? So procedurally or strategically, what you do is say, well, okay, here's the visible cancer. There's something wrong. Morphology, even standing back where I'm standing, I don't need a microscope. You can see, oh, that ain't right. So we're going to cut a couple inches one way, a couple inches the other way. And I exaggerate, it's certainly not that far, but they'll cut back quite a bit. And then we'll then take that and we'll send it off to a pathologist who will then take a very, very thin slice of the one end and a very thin slice of the other end. And if they can look at that and not see any malignancy, they'll say, well, it appears, they'll say, the expression is, it's clean at the margins. And
Yes.
that's to say that there's no evidence of metastases along the organ itself. And if there's just even a few cells, so you got a picture, you got a round little tumor thing, and then there's one little shoot that springs out like those spider plants, right? There was this little shoot that springs out like this. Well, now guess what? Now you've got 99.9% of the tumor, as RC says, but then you've got still more cells that are just going to go ahead and do the same thing further down the line. So we got to go back in and take that out. I don't want to make abdominal surgeons sound lazy, but why would you want to do that? You disrupt a lot of muscle tissue. So I'm going to take off an extra inch just to make sure I get it all right. So they can be cavalier. I'm not trying to make them sound lazy or cavalier. I'm just trying to keep the conversation lighthearted. But it's a legitimate practical decision, because if you're going to go through all the trouble of removing an inch or two out of somebody's alimentary canal that low down, you may as well take 5 or 6 inches. Who cares? Because their body's going to be disrupted enough by that procedure anyway. The little bit of meat on one side or the other is going to make a difference to them. But sort of going back to Fiona's point about the individualized nature of it, and then recalling that I'd said earlier about the sensitivity in the heart muscle tissue itself, any amount of pressure on the coronal blood vessels is potentially seriously damaging to the heart, and therefore, obviously, potentially fatal for the person. And you can't be really cavalier about, well, I'll just take off an extra inch of the heart. They're not using it all anyway, right? So it's, again, it's not, being lighthearted about it, but I just think you try to imagine psychologically what it's like then for the surgeon to say, well, yeah, I'll take off an extra inch of this colon, but then now I'm in the heart, and they've got the little microscope glasses on, and they're looking through a little microscope they have in the operating room, and they got to say, well, how much of this I'm going to take off? And I bet you there's a reason why these surgeons need their foreheads dabbed so often, because that's got to be an incredibly stressful decision to say how much of the heart are we going to take out, because it's very, very sensitive to missing pieces and incredibly sensitive to little growths that serve to constrict the coronal vasculature.
Yeah,
Yes,
that's
I
a
actually
job I
wanted
don't
to
want
mention.
ever.
Yeah, I wanted to mention one thing, Hong Tai, when you said that the pathologist is going to look at a couple of slides. I want to speak up for my pathology friends. They will, on average, look at thousands of slides from each margin. I mean, that's the kind of detail they go through. And I don't know if you've ever looked at a microbiology slide, but I couldn't imagine having to do 1,000 of those for just one patient and do that in a timely fashion so that they can get their accurate diagnosis and go on with their treatment and go on with their lives. They put in a lot of time and effort to make the most accurate diagnosis possible. And yes, to find, like you said, in case there's any one little spider branch that may have been missed by the surgery, they want to know, and they want to be very accurate. And I always applaud them for their work that they do, because I know I couldn't do that.
Yeah, well, fair enough, and I accept the correction. I hope people recognize being tongue-in-cheek. I'll always make pathologists sound like they don't work very hard and they're grossly overpaid. But as there are no pathologists showing up in Fiona's live chat to complain, that guy doesn't know what he's talking about, I'll go ahead and say snide things about pathologists. They don't talk to people. That's the hard part of the job.
That's the easy
When
part.
I worked in the pathology department, it was weird anyway. Very strange people. But you see, I think this thing about the one size fits all, not having a one size fits all, because every tumor is unique. What I'd like to do is maybe next week, if you guys are up for it, have a look at some of the tumor types that we get.
Fiona, can you hear me?
Sorry? Yep.
Can you hear me? Sorry.
Yes.
Via Bluetooth in my car speakers. But there was actually a couple of interesting papers that just came out in this issue of Cell about immune recognition of cancers.
Oh.
I think it was 2 papers. And I know the author of one of them, I think. I'm not sure.
That'd be interesting to have a look at. That's in this issue?
It was just this issue. I got the email alert literally as your hangout was starting. So
post linkies into G Plus for us, will you? When you get the chance?
I will, yeah.
Thank you.
I'm not obviously on my phone. But that could be something useful for going over, because they're specifically about the ability of the immune system to recognize tumors. But I can't say I'm familiar with the work.
I mean, I'd really like to have a look at those, because
I just thought that would be something that would be germane to this. Another thing is, my phone was not getting the best reception when you guys were talking about metastasis. Did you guys talk about epithelial to mesenchymal transition?
No, we haven't.
And cancer stem cells, because I think those are really interesting aspects of cancer. It feels horrible to say that. But it is biologically fascinating.
Yeah. See, as I say, I was thinking about doing another hangout next week. I wanted tonight's hangout to be really basic. Just the very basics of cancers and why they are such a problem. What they are, the basics of what they are and why they cause a problem. And sort of laying the groundwork for going into it in more depth in another hangout. And would you guys be interested in that next week?
Sure.
Yes. Anytime.
Cool. Hoggles? Oh, he's away from the keyboard. He's having a walk.
What time next week?
I don't know. We need to pick it at a time that suits us all, because I don't want to keep this hangout going much longer. I want to keep it as a small, neat, compact one that just covered the very basics. So Hogtie will be up for this next week as well. And I'd like to get into the genetics of cancer, because I think that goes quite a long way to explaining why each tumor is unique in each patient. When we start to look at the way that a cancerous cell, when I say a cancerous cell, we talk about a poorly differentiated cell or a non-differentiated cell, a neoplasm. We've got all sorts of words that we use for this. And what causes a cell to tip over into tip over the border into malignancy. As I say, I wanted to keep this one quite short this week. So if you guys are up for it next week, and if our audience, I'm going to ask the audience to type in the live chat about this. If the audience is up for a more in-depth look at the genetics of it next week, say yay in the chat, please. Thing is, I've got terrible lag, so it's going to take ages for what I've just said to make its way through the live chat, and keep an eye on it. I've got a couple. Yeah,
I think it's actually a very.
Sorry, on you go.
I think it's a very good idea to break it down into sections. The basics that we kind of talked about today. Well, I think some portions may have been a little too in depth for most people out there. I think we covered most of the ground. I was wondering if Jade wanted to contribute anything.
Hi. Well, yeah, just unfortunately wasn't feeling too hot, so I took a nap and overslept. The one thing I want, I know. It's a change in the weather just drives me crazy, and especially drives my arthritis crazy. But the one thing I did want to say is to tell you a story from my childhood. When I was about 10 years old, I typed this in the thingy to Fiona, but when I was about 10 years old, there was this woman in our neighborhood that everyone held in awe. People would talk about her like saying, she's just incredible. This is a woman who had breast cancer. Not once, but twice. Each time she had breast cancer, she had a breast removed. Now, back then, I was 10 in 1960. And she had had her last surgery something like 6 or 7 years before. So she'd had this surgery in the early 1950s. And back then, they removed a lot of tissue. And, they went under the arm and removed all the, you know what I'm saying. Anyway, and they even removed some muscle. So she had limited use of her arms. She couldn't, raise them so high or whatever. But she survived getting breast cancer twice. She survived both mastectomies, which, as I said, were just brutal back then. And people were just, speak of her in whispers because back then, cancer was a death sentence. When someone got cancer, that was it. Or at least that's, was the perception that most people had. And I remember when I first heard this, I looked at her in awe too, because even as a child, I'd heard the whispers of cancer. It was like, well, start buying the burial plot and get the coffin and, get all your affairs in order because you're going to be dead. And just, I can see her in my mind, like right now, what she looked like. She was a tough old broad too. I suppose maybe she had to be to survive cancer twice. But this woman was just like, nobody could believe that anyone could survive cancer. Not just once, but twice. The reason I want to mention this is to talk about how far we've come in my lifetime. And I know I'm old and all that, but it's really not that long in terms of history. But it's just astonishing today how we have so many tools. And yes, some of them are still pretty crude. Chemotherapy is, does a lot of damage to the body because, well, you're killing cells. But people live. We know people here on YouTube, on Google plus YouTube, who have had cancer and survived. More than one person, several people. Because of the way cancer was talked about when I was a child, I still get this little shudder whenever anybody says the word because it's a big, scary word to me. But I'm glad you're having this hangout. I think a lot of people don't understand, for one thing, that cancer is not one thing. There isn't a cancer out there that gets people. There are different kinds of cancers and different approaches to cancer, to how you attack it. But to see so many people surviving cancer today is just a wonderful thing.
Yeah.
And I know there are probably some people who don't realize that because they don't have a personal historical perspective like I do. But we've come a really, really long way, and we still have far to go.
Yeah, I was going to say
but
that.
Yeah, that's about it.
Yeah, we've come a long, long way. And you've actually brought up something which might be interesting in another hangout. And I'm going to have to... Sorry, I'm writing myself a note, and I can't write and talk at the same time. Radical versus conserve. Sorry, I mean, I'm a bit of a little brain at the moment because I'm really tired. So I'm just thinking about possibly roughly the same time next week. Does that suit everybody? Or I can make it an hour later. Seeing as you were all an hour late. Sorry?
I'll try. It's hard. I'm very busy these days, but I will definitely try because this is very. And if you said if it's genetics, it's probably the only one that I can actually talk about somewhat somewhat intelligibly. I don't know anything about treatment or much of what goes in clinical, so I will definitely, if any of them that I can make, the genetics one, I will make a special effort to be there.
Right. Chris was saying a day earlier. Today's Thursday, isn't it? So that would be. Could people make it midnight GMT next Wednesday? As in,
yeah,
on
Wednesdays
the
are better for me too, but are better for me too as well. So.
Right. Okay.
What's the GMT you speak of?
Midnight GMT is 7 p.m. Eastern.
I kid you, Fiona.
Yes, I know, but I thought I'd better put it out there. I've actually now got EST on my phone. So I have GMT and EST. So that
I think that would be a great time. But again, my schedule is dependent on the workload I have, so I'll do my best to make it.
Cool.
I sure hope I'm still not at work.
So that will be installment 2. We'll actually look at the genetics and go into explaining why we're saying that cancers are very individual. Listen, I want to thank everybody for coming tonight because it was very interesting. And also, I'd like those that have been in the audience who've said thanks to us, you know, for doing this. If they've got any questions, we'll be here again. If we're here next Wednesday, if they think up any questions in the meantime, we're happy to attempt to answer them, not promising that we can. And we'll try to look more at the cellular mechanisms rather than, you know, the system-wide.
Sorry to interrupt. I was wondering if maybe we could take a couple of examples and really kind of highlight them. Like I know we bounced around from colon cancer to lung cancer.
Mm-hmm.
You think might be particularly interesting within the topic of genetics?
Yes.
TP53. It's mutated in everything. Cancer.
Yeah. Well, one of the ones I want to include in it is retinoblastoma.
Retinoblastoma, yes. I was wondering if Hogtie had any input on this.
BRCA1,
but I guess it's away.
BRCA2.
Yeah. Because
from what I understand, he's of a bunch of the bunch of famous oncogenes and tumor suppressors, but as far as what specific cancer they map to, I'm useless.
Yeah, I'd like to look at the head and neck cancers because
I did work on that for a while.
Right. So we'll plan that for next Wednesday, midnight GMT. I'll be turning into a pumpkin at that point. I want to thank everybody for coming. I want to thank our audience for actually being civil in the live chat. Been amazing. And we'll see you all again next week. Say ta-ta, everybody.
Ta-tas, save them.
Ta-ta.